Good morning, everyone. I'm Daniel Marco from Hospital Clinic in Barcelona. I'm going to present this case entitled Human Herpes Virus 8 and AIDS, Old Friends and a New Foe. It is based on a 36-year-old Paraguayan man who was in Spain only for tourism with no relevant medical history with the exception of a monometameric herpes zoster. He was admitted because of extreme fatigue and general malaise with progressive abdominal distension and also lower limb edema. At admission, he was pale with icteric mucosa and large lymph nodes in several territories and an oral candidiasis. And the abdominal distension was due to a combination of hepatosplenomegaly and grade 1 ascites. Remarkably, he had violaceous lesions in the skin, very suggestive of Kaposi sarcoma. And remarkably, there were no reports of fever, unintentional weight loss, or night sweat, or any other localizing symptoms. So, blood tests at admission showed a severe normocytic anemia with thrombocytopenia, normal blood smear, normal renal function, but abnormal liver tests with cholestasis, hypoalbuminemia, and a polyclonal hypergammaglobulinemia with marked elevation of acute phase reactants. Serologic testing showed positivity for HIV with very high viral load and also viremia for HHV8 and Epstein-Barr virus, and immunologically he had only 4 lymphocyte CD4 T lymphocytes with very low ratio CD4 to CD8. Pleural effusion was confirmed by a CT scan, also ascites, the hepatosplenomegaly, and lymph nodes in abdominal and pelvic cavities. So we were facing an advanced debut of HIV infection, which I like to call the overlap syndrome, because it reminds me the clinical dilemma, which is common that with the internet face between the principle of Occam's razor, who impels us to think of the simplest explanation, even for the most complex clinical scenario, the famous single unifying diagnosis, versus the more nuanced vision of Carl Saint, who reminded us that indeed patients can present with more than one concurrent condition, and especially HIV patients are known to have more than one AIDS-defining disease at time of presentation due to very profound immune dysregulation. So, apart from a toxic cause, the hepatomegaly with cholestasis was thought to have an infiltrative nature. We thought of basically lymphoproliferative disorder or a disseminated Kaposi disease, but also opportunistic infections such as disseminated mycobacteriosis, whether tuberculous or non-tuberculous, invasive fungal infections by dimorphic fungus or cryptococcicosis, or rare infections such as disseminated cytomegalovirus disease, visceral leishmaniasis, or bartonellosis. For the cytopenia, we also thought on an infiltrative cause of the bone marrow, but due to lymphadenopathy and hyperinflammatory markers, we also thought on multicentric Castleman disease or a Kaposi sarcoma-induced cytokine syndrome, or an otherwise non-specific hemophagocytic lymphohistiocytosis, which could be secondary to any of the prior possibilities. So, as soon as the relevant clinical samples were taken, an active antibiotic therapy against mycobacteria and antiretroviral therapy were started on the basis of whether it was a lymphoproliferative disorder or an atypical mycobacterial infection. It would be advisable to achieve a quick immune reconstitution. And also, the skin biopsy confirmed the nature of the Kaposi sarcoma in the skin lesions and posed us the relevant question of whether this patient could benefit or not of corticosteroids empiric therapy. So, liver biopsy did not help us because it only showed a non-specific infiltration of hepatic sinusoids responsible for the cholestasis, but lymphadenopathy analysis showed an atypical infiltration by atypical plasma cells and a distortion architecture, leading to the final diagnosis of a primary fusion lymphoma due to positivity of HHV8 and Epstein-Barr virus immunohistochemical stains in the tissue. So an aggressive chemotherapy with corticosteroids and also rituximab was started, but unfortunately, patient did not respond well, evolved with multi-organ failure, subsequent viral reactivations, and a premature exitus in less than a month. So, returning to our overlap syndrome, we concluded we had a clinical conundrum driven by an over-reactivation of HHV8 leading to a KIGS and also two neoproliferative disorders associated with it, the Kaposi sarcoma and the extracavitary variant of primary effusion lymphoma. So how can this happen? Just HHV8 is an herpes virus, DNA virus with universal distribution, interhuman fluid transmission, which infects predominantly lymphocytes and endothelial cells, and it can remain latent for a lot of time in the cells closed up in an episome. But if immune control fails to control viral replication, it can lead to diverse diseases, ranging from the 4 types of Kaposi sarcoma, 3 types of lymphoma. Within them, the most typical is the primary fusion lymphoma or the non-lymphomatous multicentric Castleman disease. Otherwise, it can lead via viral production of cytokine viral interleukin 6. It can mimic a cytokine-driven hyperinflammatory syndrome or an otherwise banal primary infection in pediatric population with fever and a rash. So it is precisely the balance between the lytic and the latent phases which is controlled by immune system, and these regulations of it will drift towards oncogenesis or to hyperinflammatory disorders. A few words about KICS, our recently discovered foe. It is situated just precisely in the intersection between oncogenesis and other cytokine-driven syndromes. Its clinical diagnosis relies in the presence of non-specific clinical signs, such as edema, hypoalbuminemia, and anemia, but with the demonstration of high viral load in plasma and other supporting analytical data. This is the clinical criteria that had been proposed. So I really would stress that we should think on KICS and other HHV8-related pathologies, not only in patients with typical constitutional syndrome or B symptoms, but also in those immunosuppressed patients presenting with hypoalbuminemia or a subacute inflammation syndrome. Thank you very much.
Thank you. Roman, over to you.
Well, let me start with a non-North American angle. You mentioned that this was a visitor in Spain?
Yeah.
Okay. Who paid for all those wonderful tests and therapies? I'm curious.
No, finally, I think it got no payment because we have a public health system. The patient was here as a tourist, and he did not pay. He did not have any family here in Spain. So after his death, I think it got all unpaid.
Okay. Well, in the next hall, we have artificial intelligence session, and I start to have suspicion that for a lot of those cases, we'll need this kind of help. We'll see what future shows.
A short comment. Herpes viruses are ubiquitous, so it is not so very strange that the co-infections of that viruses are very common even in healthy adults. In this case, HHV8, now known better as Kaposi sarcoma herpes virus, is a director on the scene, and all the clinical conditions you have mentioned here and the coincidences between regulation and cell saving and cell dysregulation depend on the certain mechanism. For HHV creates 2 clusters of the Kaposi sarcoma cells. One expressing lytic genes of this virus, and the second of latent genes of this virus. So the coincidence of the present immunity in the patient when it lowers the advantage of one of these gene expressions lines are difficult to predict. These actors on the scene need also a director which is a thinking clinician. Congratulations.
Thank you for the comment. Indeed, the synergy that exists between the 3 viruses, not only HIV and HHV8, also Epstein-Barr virus, are responsible completely for the oncogenetic processes that, for example, this patient had. What we would like to stress in this case as a director of the scene of HHV8, which of course needs a source of immunosuppression to act so aggressively, like in this case, whether it is AIDS, which is the most common situation worldwide, but also immunosuppressive therapies, for example, for organ transplantation. It's the other cause of Kaposi sarcoma, for example. And then in this case, HHV-8 was responsible for the cytokine-driven hyperinflammatory syndrome, which is called precisely, as you said, Kaposi sarcoma-induced cytokine syndrome. We think, of course, in the lymphogenesis of the primary fusion lymphoma, there were, of course, the Epstein-Barr virus and the HHV, and of course the HIV. But the kicks it had, it was defined with only the HHV-8 uncontrolled replication. Another proof of that is, I had to shorten it all, but with antiretroviral therapy, HIV viral plasmatic load rapidly lowered, and it was at that moment when HHV-8 exploded and the patient started to be febrile and with all the other symptoms that in the first moment he lacked. Thank you.
So thank you. We have to move on. Okay, last question.
Well, congratulations, good presentation. And you mentioned the third virus. My question is about that. Just will you confirm, please, Epstein-Barr virus viral load was also at the level of the 100,000 levels? And if it's so, you haven't mentioned anything about that because it could cause a Hodgkin. You missed that. You're giving steroid. Did you look at carefully about a lymphoma? Because it will almost give the same clinical presentation.
The histopathologic reasoning was difficult in this case, indeed. Liver biopsy, we relied a lot on liver biopsy, which didn't help us much. And afterwards, lymphadenopathy histopathological examination was not straightforward. It was necessary to do a lot of immunohistochemical stains to finally. It is not easy to diagnose a primary extracavitary primary fusion lymphoma, precisely because it has shared characteristics with a diffuse B-cell large lymphoma or also the anaplastic lymphoma, which also involve Epstein-Barr virus. So in this case, finally, the pathologist thought in this condition, but it was not easy to say it properly.
Thank you so much. Time is out, so thanks.